Good morning, everyone. My name is Suresh Yelika, surgical resident from Stony Brook University. Thank you, Sages, for giving me this opportunity to have an oral presentation today morning. The title of the presentation, Does Adaptation of Emergency General Surgery Service Model Affect the Volume of Cholecystectomies at a tertiary care center? I don't have any disclosures. The aim is the same, to determine the association between the adaptation of emergency general surgery service and the volume of cholecystectomies at the tertiary care center. Just a brief introduction about this model. We started this model in November 2013. This mainly to minimize the number of patients lost to follow-up. We started the service with 4 full-time attendings who are fellowship trained in minimally invasive surgery, and which was started in November 2013. And they take a call for whole week, and they take a call, home call at nights. Next, the methods. It's a longitudinal observational study was conducted prior to and following introduction of the EGS model. The model was started in November 2013. We observed the patients 3 years before and 3 years after. Before there was Acute Care Surgery Service, which is trauma surgeons, basically acute care surgery. They used to take care of all the emergency consultations from the emergency room and emergency surgeries. Inclusion criteria using New York Sparks database. Sparks database, which is nothing but a statewide planning and research cooperative system. This database has got the patient characteristics, demographics, and diagnosis and the treatment planning for both inpatients and outpatients. So we included the patients who presented to the emergency room with a diagnosis of cholecystitis with gallstone and without gallstone disease, and biliary colic and biliary dyskinesia. So we compared the rates of open cholecystectomies, open and laparoscopic cholecystectomies performed 3 years prior to and 3 years following the adaptation of EGS model. We excluded the patients who had missing data and less than 18 years of age. So statistical analysis, we performed a multivariate logistic regression model to compare incidence of cholecystectomy at our institution, both pre and post EGS introduction. Rest of the state was used as a control group while adjusting for confounding factors. So if you see this slide, this is the number of ED visits and cholecystectomy rates of New York and Stony Brook University Hospital. So you see on the x-axis, the middle line on the x-axis is the period where we started the EGS model, and we compared 3 years before and 3 years after. And if you see on the y-axis is the number of percentage of cholecystectomies performed. In this slide, the red line shows the red line on the graph shows the number of cholecystectomies at New York State, which was relatively steady at 38.01 from 2010 to 2013 and 39.2% from 2013 to 2016. Whereas if you see at Stony Brook, the rate has been increased from 28.21% prior to EGS to 40.2% after EGS introduction. This slide shows the lap and open cholecystectomy rate for New York and Stony Brook University Hospital. On the topmost part of the slide on the graph shows the laparoscopic cholecystectomies performed and compared between New York State and Stony Brook. So if you see, the rate of laparoscopic cholecystectomy has been increased from 25.7 to 39.9% at Stony Brook. And at New York, it's a little bit increased, 35.9 to 38.5, but it's almost the same by the end of the 2016. Whereas at the bottom of the slide, you can see the 2 lines representing open cholecystectomies. The rate of open cholecystectomy has been decreased at Stony Brook from 2.77% in 2010 to 0.35% in Stony Brook University Hospital. This trend was almost similar at the other institutions in the New York State. The indications of performing cholecystectomies. If you see after the introduction of the EGS model, the patients who are diagnosed with cholecystitis has been increased from 46 to 53%, whereas there is decrease in other diagnoses such as biliary dyskinesia and gallstone without mention of the cholecystitis. And this slide shows the number of ED visits and cholecystectomies performed in New York State versus Stony Brook. At New York State, most patients, 89 to 88.4% had cholecystectomies during their first initial visit. And at Stony Brook University Hospital, the percent is very minimal increase from 83 to 85, but almost the same when you compare with the New York State. Almost 85 to 90% of the patients had cholecystectomies during their initial visit. The main limitations of the study, it's a retrospective study and observational study. Did not assess other outcomes such as length of the stay, readmissions, and our follow-up. And one more point, we had one CBD injury after post-EGS introduction, and before we had 3 CBD injuries. That was not in the slide, sorry. The conclusions of the study. After introduction of the EGS model at the Stony Brook University Hospital, there is significantly increased rate of cholecystectomies from 28.1% to 40.2% over a 6-year period. We hypothesized thus the introduction of the EGS model led to consistent perioperative care for all emergency cholecystectomies. And this study can be a model for future focus on other surgical emergencies such as laparoscopic appendectomy and other acute abdomen, such as perforation or other causes of acute abdomen. That's it. Thank you very much.